Hello and welcome to the NCAI Policy Research Center webinar series. We will be starting in a few minutes. Thank you. All right, let's get started and welcome to the NCAI Policy Research webinar series. Hello, I'm Dr. Yvette Rubidoux, and I'm the Vice President for Research and Director of the Policy Research Center at the National Congress of American Indians. Welcome to our NCAI Policy Research Center webinar series. Today, we will focus on tribal epidemiology centers, critical resources during the COVID-19 pandemic. We're so glad you joined us today. I encourage you to join our listserv for announcements of webinars and other research and policy data related information by emailing research@ncai.org. We will also announce our webinars on Twitter and on our website. If you missed any of our webinars, the recordings are usually available on our NCAI YouTube page or on our website, www.ncai.org/PRC under Events and Webinars. So here's an overview of today's agenda. I just provided a welcome. Our speakers today are directors from the Tribal Epidemiology Centers, and you can see we will have 4 speakers. Dr. Victoria Warren Mears, Director of the Northwest Tribal Epidemiology Center. Ramona Antonez, Director, Navajo Epidemiology Center. Vanessa Cresci, Director, California Tribal Epidemiology Center. And Abigail Echohawk, Director, Urban Indian Health Institute. Once the speakers are done with the presentations, we will reserve time for questions at the end. We will have several other Tribal Epidemiology Center directors available to take questions. Before we get started, I'm going to review a few housekeeping items and let you know how you can participate in today's web event. So this is a depiction of the go-to attendee interface, and it is made up of 2 parts. The viewer window on the left, which displays the presentations, and the control panel on the right. I'll quickly navigate how to use the control panel so you can readily participate in today's webinar event. By clicking the orange arrow, you can open and close your control panel. And then here is where you can find all the information about your audio connection. We recommend dialing in by a phone rather than the computer, as it tends to limit feedback. To dial in, you will find the number and access code here, along with your unique audio PIN. As you can see, all attendees are currently muted in listen-only mode. At the end of the presentation, we will be open for questions and answers, or Q&A. At this time, please submit your questions via writing them in the questions pane. And as a reminder, today's webinar is being recorded. After the event, you will receive an email with a link to a short evaluation, and the recording will be available soon on our NCAI YouTube page and our PRC website in a couple of days. And now, I'm happy to introduce our first speaker, Dr. Victoria Warren Mears, Director of the Northwest Tribal Epidemiology Center. Welcome.
Thank you, Dr. Rubidoux, and thank you for inviting me and the other tech directors to present on this call today. I bring you greetings on behalf of the Northwest Tribal Epidemiology Center and the Northwest Portland Area Indian Health Board, and we're honored to speak to you today. Next slide, please. Before we begin, I'd like to give you a little bit of an overview about the Tribal Epidemiology Centers. As you can see from this map, there are 12 centers throughout the United States. They roughly correspond to each Indian Health Service area. Important exceptions to note are that the Intertribal Council of Arizona serves both the Phoenix and Tucson area. The Navajo Nation has their own Tribal Epidemiology Center, and the Urban Indian Health Institute, which is located in the Portland area, serves urban programs throughout the United States. And so we are roughly located everywhere, and there's one epicenter that's available to each tribe or urban program throughout the United States. The techs were formed in 1996, and first funding was provided to 4 techs in 1997. This funding was made available because of the advocacy of tribal leaders just like you, who felt it was important to have access to accurate and timely data for Indian country. Next slide, please. Through the Affordable Care Act, the Tribal Epidemiology Centers were designated as public health authorities for several core functions. There are 7 of these that we are to serve tribes and urban programs as a public health authority for these functions on the direction of the tribes in our region. So the things that we do on behalf of tribes as tribal epidemiology centers are collecting data, evaluating data and programs, assisting with the identification of health priorities with tribes and urban programs, making recommendations for health service needs, making recommendations for improving healthcare delivery systems, providing epidemiologic technical assistance to tribes and tribal organizations, and providing disease surveillance to tribes. So today, that last bullet is where we'll be starting related to COVID-19. And I'd like to present to you the activities of the Northwest Tribal Epidemiology Center. Next slide, please. So we'll be talking today about the Northwest Tribal Epidemiology Center COVID-19 response. And I've included my contact phone number there so that if you do have any questions about this response, you can feel free to call me or text me, and I will be happy to get right back to you. Next slide, please. The Northwest Tribal Epidemiology Center is a part of the Northwest Portland Area Indian Health Board, and as I mentioned, was established in 1996 as an epidemiology and research center. Our first funding from Indian Health Service came in 1997 when we established the Northwest Tribal Epidemiology Center formally and established our working relationship with the tribes in the Northwest. Our specialties include research, public health programs, data management, epidemiology, and many others. I've included a depiction of our structure here, which indicates that the Northwest Tribal Epidemiology Center, as the term is used in the Northwest, is an umbrella or a departmental designation for many programs that you may be familiar with in our region, including the Thrive program, the Indian Country Echoes, Northwest Tribal NARCH program, We Are Native, and many others. And not all of our programs have a logo, so they're not all listed there, but we do have a great number of programs that fall under our designation of the epicenter. Right now, we also have an IHS medical epidemiologist assigned to us. We have an EIS officer from CDC, and that EIS officer will become an alumni with to continue responding to the COVID-19 pandemic in the next year. And we also have a PHAP from CDC who's assigned to us for an experience as well. So right now we have about 56 people, more or less, who work at the Tribal Epidemiology Center, providing services under the direction of the tribes of the Northwest. Next slide, please. So the Northwest Tribal Epidemiology serves all of the Northwest tribes, that meaning the states of Idaho, Oregon, and Washington, and tribes with their locations in those states. We have extensive data sharing and data use agreements with tribes, state health departments, and other regional partners. And we have well over 22 data agreements, which allow us to provide health profiles for the region and do surveillance. And again, as I mentioned, UIHI is located in our region. We partner with them, but the UIHI serves urban Indian health programs nationwide. For the purpose of COVID-19 surveillance, we do have our urban programs also reporting to our center because we're supporting the Portland area Office of Indian Health Service in that effort. And so we have developed limited data sharing agreements with our urban partners for the data that's coming to our center, which is testing data for the Northwest. So currently we're conducting COVID-19 surveillance in partnership with the tribes and the Indian Health Service Portland area office. And we also are conducting a survey on tribal revenue lost during the COVID-19 closures for healthcare facilities. And we have some preliminary results, and it is appearing that many of our tribal nations' healthcare programs are losing upwards of $500,000 per month during this response, largely due to having closing dental, behavioral health, and clinical programs, and simply being open for emergency and testing services. Next slide, please. We began our response on February 24th, 2020. We activated a 7-member response team, which includes our CDC partners and partners from IHS, and we established a website. Initially, when COVID-19 started, we weren't certain how much real estate we needed on our website for COVID-19, so we initially put information on the front page of our website as sort of a shout out or emergency place to look. And we quickly decided that was inadequate for the amount of information we would be providing. And so we established the page, which you see in this slide, and we welcome you to visit. The COVID-19 weekly call with tribal and state partners was initiated shortly after this to respond to tribes' requests for information in a coherent way and coordinated so that we could manage the number of calls we were getting initially with questions about COVID-19. Also, very early on, we began producing educational materials, and on our webpage, there are educational resources that were produced both early on and as we've moved through the outbreak in response to tribal leaders' requests. We adjusted our surveillance with the Orpheus and Essence systems in Oregon and Washington states. And unfortunately, the state of Idaho does not participate in this surveillance system. And so we have not been able to establish a more real-time surveillance with them under existing data sharing agreements. But our adjustments allowed us to track influenza-like illness, COVID-like illness, and then later, as we were working through our surveillance, we also received reports from tribes that the visits for mental health and substance use, there was a perception that they were increasing in emergency departments. And so we were able to add that to our surveillance template that we're using. And indeed, we saw increases in disaster-related mental health, suicidal ideation, suicide attempt, and substance use overdose. And so that data is available on our website. You can take a look at that on state summary levels. And then we also began the data collection for the Portland area Office of Indian Health Service. And the screenshot on the left is a little overview of the front page of our website. And again, I would invite you to go there to take a look. Next slide, please. As we've gone on responding for a longer period of time, we've developed other tools. Key among those is a COVID-19 clinical echo, which was established by our Indian Country Echo program. And this call is held twice weekly and brings together clinicians and other healthcare professionals from throughout the United States to provide information on testing, surveillance, treatment, some on traditional healing methods, and many other topics that have come up, in addition to providing information on the epidemiology and progression of the outbreak. We've had on average over 150 participants on each weekly call since its inception, and we are serving people throughout the Indian healthcare system with this call. And again, if that's something that you as a leader would be interested in attending, you're welcome. All of that information is on our website again. We continued development of media materials, and our second target was a youth focus. This week, we're also planning on releasing media on keeping elders safe, and so we've begun that. We are doing ongoing training also and technical assistance. Our current topic is outbreak investigation and contact tracing, and in the last week, we've trained 90 individuals to be able to do that. 20 of whom were from tribes, or excuse me, 20 of whom were from our Tribal Epidemiology Center, and 70 of whom were from regional tribes. Next slide, please. And we also have developed a COVID-19 data dashboard. The summary reports on a weekly basis are on our normal COVID-19 website, which the link was provided before to you. We also have a specific data dashboard, which you can look at. And we have this for Washington and Oregon states, and this is the emergency department surveillance. I put an example of the top of the data dashboard here for you, and it features the AIAN population information that we have in burgundy and non-AIAN in gray. Next slide, please. We also have some additional planned actions, and right now we have taken on the Environmental Public Health Program from the Area Office of Indian Health Service as of January, and so we're providing environmental public health guidance for reopening of tribal enterprises. We also have been working with the Columbia River Intertribal Fishing Commission to ensure that fishermen are contacted in isolated villages and have testing available as needed and education about COVID-19 in terms of trying to protect the fishing community, as well as knowing that's a highly mobile population in our area. We also have more social media coming, including Safe Sweats. The clip of the first video in around Safe Sweats is shown behind. You can see the photo of that, and you'll see that on our social media later this week. We also are looking at maternal child health topics and battling depression. And we have an ongoing media plan to release those going forward. We'll be continuing our clinical revenue study. Many of our tribal leaders have noted that they anticipate shortfalls to continue well throughout the summer as we're slowly progressing through the various phases of reopening and anticipating how to do clinical services and behavioral health services. So we'll be continuing that study, and we'll be using that data for advocacy on behalf of the tribes of the Northwest. And really our entire effort has been to protect the tribal population as best we are able, to also just assist tribal leaders in having the data that they need to provide advocacy for tribes in our region. Next slide, please. This quote that I've provided is something that our tribal chair for the board, Nicholas Lewis, said early on in the epidemic, shortly after we had declared a public health emergency on behalf of the Northwest tribes. And I won't read this to you in its entirety, but an important concept here is that tribes should reach out and help each other however they can. And we really need to get through this together as a team effort. So again, if you have any questions at all about the response of the Northwest Tribal Epidemiology Center, please feel free to call or text me. I've included my phone number and my email. I don't recommend that you use my desk phone, which some people in the Northwest do have. Since we're all teleworking now, it's really best to get me at my cell phone, and I'm happy to help you in any way possible. So I'd like to thank you again for giving me the opportunity to speak today. And as always, we stand by ready to help all of our Northwest tribal leaders. And if there are others of you who would like additional technical assistance, we're happy to help. So thank you very much.
Thank you so much for that great presentation, Dr. Warren Mears. All right, our second speaker is Ramona Antonez, who is the director of the Navajo Epidemiology Center. Welcome.
On behalf of the Navajo Nation and the Navajo Department of Health, we'd like to welcome you to the Navajo Epidemiology Center presentation. On Navajo, we are referred to as Nasni Naska, which is disease surveillance in epidemiology. The vision is to empower Dene people to achieve Hojon through Nasni Naska. We are pleased to present to you the Kusintsagi 19, COVID-19, which means the cough that is big, which is a translation of pneumonia, and the 19 signifies that this is the severe kind of pneumonia. We also would like to invite you to our webpage there at www.nec.navajo-nsn.gov. Next slide, please. Yate Shea Ramona Yanishia Topahanishledo Iroquois Naide Bashishchin Okidine Dashache Nana Iroquois Naide Dashanale Akut Sanishle. What I just shared with you is what we refer to as our kinship on Navajo. We are a matrilineal society. We identify our mothers, fathers, and our grandparents, our grandfathers' clans, and it identifies a person's role and responsibility in our society, as well as where we are from. Navajo are Dene, the people. As you can see, we are from the Four Corner region of the United States, which encompasses the New Mexico, Arizona, and Utah. There you'll see the Navajo Nation. We span over 27,000 square miles. We are challenged with this in a pandemic at this time. We're also comparable to the size of the state of West Virginia. You can see there in the Navajo land, which is the Nebuchadnezzar, is the land that's under our feet and that we walk upon. The orange color is the eastern side of Navajo, and you can see the smaller dots there on the bottom right-hand corner, which includes the Tohajale, Alamo, and Rama, and they are also providing receive services from Albuquerque area. And I'm going to take you back to the larger, where you also see the Navajo area Indian Health Care Services, including the Chinle, also Central, Fort Defiance, Tuba City, and Northern Navajo. And the gray right in the middle is the Hopi Nation. Next slide, please. As we go through the slides, we want to share that on March 11, 2020, the Navajo Commission on Emergency Management declared in a state of a public health emergency for the Navajo Nation due to the confirmation of the novel coronavirus in the regional area surrounding the Navajo Nation, and there's a tribal resolution there. Next slide, please. This, as we had stood up the Health Command Operation Centers, we've had changes over time about our organizational chart, and this is the most recent, and I please know that this is at a glance and not sharing the actual organizational chart because it has names and identifiers on there, but I just wanted to get to the real overview of this, and it's a unified coordination. So there's the executive authority, which includes the office of the president and the vice president of the Navajo Nation. And then we move into the Navajo Department of Health, the Indian Health Services, the Bureau of Indian Affairs, and tribal organizations that help with the unified coordination as we all work to deaccelerate and stop COVID-19 here on the Navajo Nation. I just want to also share with you that on the side, there's many partners that contribute into this. As we move through COVID-19 response, there is the branch there, and we branch off into the medical side where the healthcare facilities are operating. You can imagine there's all types of many moving parts that are in play for the medical component. And then I want to take you to the public health arm, where not only are there other functions, but we do want to share with you that this is where contact tracing is identified, as well as epidemiology. And next slide, please. We want to share with you the team of the Navajo Epidemiology Center, which includes epidemiologist David Foley and Del Yazzie. We also have Simontel Francisco, Deidre Gray Eyes, as well as Dolores Vicente, who are support, and all of them, they have high-level technical capabilities, and they keep me in line in terms of all the technology that's available, and I'd like to share that with you more so, with additional team members, including Darlene Tracy, Cheryl Woolley, and Forrest Lester, who are all part of the support team to the situational awareness for the operations. As we move on the other side, their partners include Navajo Area IHS, which are the federal facilities on the Navajo Nation, including Crown Point, Chinle, Kayenta, Gallup, Northern Navajo, and Shiprock. As we continue on, we identified the Albuquerque Area IHS, Tohajale, Alamo, Rama. We do have tribal organizations that we refer to as Public Law 93-638, Tuba City, Winslow, Utah Navajo, Teotihuacan Medical Center, and Sage Memorial Hospital. We have effective working relationships with the states of Departments of Health, New Mexico, Arizona, and Utah. Next slide, please. What we are contributing to in this response in mitigation and eventually recovery of COVID-19 is the collaborative data collection with all our partners. We started to monitor and surveil the area before COVID-19 came onto the nation, and we are preparing, and we actually had our first case on March 17, and from there we've had cases every day that we are confirmed with. So what we do is, this is the situational awareness report, and this report shows 70, and what we have there is the declaration of public health emergency. And we have here, which I'm not sharing, but it is available. It does say the number of tests, the number of negative tests, the number of positive cases on the Navajo Nation, of residents who live and reside on the nation, as well as the average age. Unfortunately, when we are speaking about a pandemic, there are mortalities that have occurred on the nation, and we're able to report that on this situational awareness. And we have epi curves, like on the figure 3. We took some information off as identifiers, but you could see that there's various counties that we work closely with, and we're able to continue to look at the line list, the data that we have, and make epi curves to that, and working in close collaboration with Navajo Area Indian Health Services as well as the tribal organizations. Next slide, please. We want to also invite you to our webpage. There's the address, and there you'll see the dashboard where there's the Kusantagi 19. We have the positive cases, the date that we are last reporting on. And I want to take you to the other side where it shows the number of cases per region. And when a person can click there for additional information on the total cases for that particular service area. This is available on the web page. Next slide, please. And we also want to share that this is a one-pager back and front about what the Epidemiology Center is doing to respond to COVID-19. We also share that on the dashboard on the second page there, that it's for the healthcare providers. They're able to see that. We're going to go live with that. I believe we went live yesterday, where all the reportings that come in, they're able to access that. And very quickly, we want to share with you that we have contact tracing, and we're using a platform called ComCare. And we're working to stand that up to, one, slow the spread of COVID-19 and then stop the spread of COVID-19. I also want to identify that we have had 2 epi aids from the CDC. This group on the right-hand side is with the Window Rock backdrop is our first visit, and the second is when they're here now helping us with strengthening our contact tracing. Next slide, please. With that, we want to say ahiaha on behalf of the Navajo Epidemiology Center for taking some time to hear our presentation, and we invite you to this really nice 30-second clip that's available through one of our partners about using the Navajo language and identifying the Navajo Nation, the Navajo culture, and how we are continuing to do primary education and the outreach to our communities. And there's contact information there. At this time, we'd like to end our presentation.
Wonderful. Thank you so much. And now we're going to try to show the video. So hold on.
Hat ishi toit ingo ikinch yihnut in ako ikinsikes chainset haleit ago nalni eston go antadilni eight eya anifi atidil so ilheje do nke ol ilbe inna njone etla allah de elini at.
We stay at work for you.
Please stay home for us.
Haasha nalni huyat adadilni.
All right. Thank you. I hope that you could see that video. It's beautiful, and I have to brag, the female doctor, Dr. Young, was one of my mentees when I was back at the University of Arizona. I'm just so proud she was in the PSA, so thank you so much. That was beautiful. We'll have that link available on our website as well. All right. Our next speaker is Venetia Cresci, Director of the California Tribal Epidemiology Center. Welcome.
Thank you. I'm Venetia Cresci. I'm the Director for the Research and Public Health Department at the California Rural Indian Health Board. Venetia Cresci Yanisha, Klashi Nishle, Maidishkishni, Bashachi, Tachini, Edishache, Do Torichini, Edishanale. I also come from the Navajo Nation, and I want to thank both Ramona and Victoria for sharing the great work that they are doing on behalf and with the tribes that they serve. Next. So the California Tribal Epidemiology Center was formed in 2005. It is a statewide center that serves the state of California, that includes the 109 federally recognized tribes, tribal health programs, and urban Indian programs within the state. It is housed within the Department of the Research and Public Health. We have a total of 15 staff that work to provide training and technical assistance. And together we have 34 data sharing agreements that allows us to share data with tribes, tribal health programs, and urban Indian clinics. We also have access to a medical epidemiologist and a registered nurse who provide support to our staff. Next slide, please. So CRIB and CTEC had activated an internal task force in March, early March of this year. Immediately, we began to have internal task force meetings. In addition, we started weekly statewide COVID-19 calls that are available to tribes, tribal health clinics, and urban Indian clinics to participate. We developed a web page that has our resources available. We are in the process of revamping our format and layout, and that should be live next week. We've also developed educational materials and guidance that are available statewide. And as we receive technical assistance requests for additional guidance, we provide those and create those materials and disseminate those statewide. Next slide. So this is an overview of the work that we conduct as it relates to COVID-19 response. We provide trainings and planning support across the state. Most recently, we have been increasing our response related to contact tracing and case investigation. We provide trainings, and we have conducted 4 trainings so far to tribes and tribal clinics. We have developed forms and scripts. And in fact, we are providing phone contact tracing and have, in one situation, have provided training to the county so that they can increase their capacity and support to the tribes in their area. We've also have provided guidance regarding infection control. We have provided a number of educational webinars and provide assistance in to updating or developing emergency preparedness plans. As it relates to surveillance and epidemiology, we put out weekly situational reports that includes data for the state and also for tribes. We analyze the IHS California area data, and when we look at the data, we identify any positive cases and reach out to those clinics and tribes to identify any needs. We conduct syndromic surveillance in addition to providing TA data requests. For communication and resources, we develop guidance materials. We produce educational materials and videos. We are in the process of developing some PSAs that will be disseminated across the state. We coordinate PPE and testing needs and gaps and share those needs with the state and the federal agencies. We provide assistance with grant applications. We continue to advocate and enhance our partnerships with state, county, and federal agencies, and that includes the California Department of Public Health, the California Office of Emergency Services as examples. Next, please. These are examples of 3 ads that we have created and disseminated. We have taken individuals and asked individuals from across the state to participate in our educational campaign. And it's very important to CTEC that we provide feedback, we provide materials that come from the communities. It's a community approach. So these are individuals that have shared their own words in order to provide support to tribes and clinics across the state. Next slide. These 2 are examples of resources that we have disseminated. Up top is our situational report. This is just a snapshot of one of our pieces that we have created. So we have disseminated so far as of May 7th, 41 situational reports. These are created and disseminated on a daily basis. We have also created guidance for community health representatives. This is just an example. As needs come up, we develop materials and disseminate it across the state. Next slide. And lastly, this is my contact information. We have worked over the past few months with all of the tribes and clinics across the state and identifying what their gaps and needs are and identifying ways that we can be of support to them so that they can prepare for COVID response activities. Thank you.
Great, thank you so much for your presentation. That was really great. Before I introduce our last speaker, I want to remind everybody, if you'd like to ask questions, please write your questions into the questions pane and we'll be able to take questions after our last speaker. And I am pleased to introduce Abigail Echohawk, who is the director of the Urban Indian Health Institute. Welcome.
Thank you so much, Dr. Rubidoux, and I'm excited to be here and to hear the incredible work of my fellow Tribal Epicenter directors, all of us who have been working hand in hand with our communities to address this pandemic that is currently affecting not only Indian country, but this country and also internationally. I'm Abigail Echohawk. I'm a citizen of the Pawnee Nation of Oklahoma on my father's side, and I was born and raised in the heart of Alaska amongst the upper Athabascan people. So I'm very fortunate to have been raised in rural Alaska, but also to currently live and work in the Coast Salish lands, currently of Seattle, Washington, in an urban Indian center. Next. So what is the Urban Indian Health Institute? That's a really good question. As you've heard from my fellow tech directors, they've talked about serving the IHS areas. And so the 11 other techs are serving the IHS areas, which encompass the entire United States. Most of their efforts are working with the federally recognized tribes with the scarce resources that we all have. We receive core funding from the Indian Health Service and also supplemental funding from the CDC and others. Despite that, we still have to work collaboratively together in order to serve our communities well. And one example of that is the Urban Indian Health Institute and the Urban Indian Health Programs. So we are the only tribal epidemiology center that works nationwide. I'm currently working specifically with 62 organizations in 29 states and more than 130 different counties. 41 of those programs are funded by the Indian Health Service as Urban Indian Health Programs. So the Indian Health Service program includes the I, which is the IHS operated facilities, the T, which are tribally operated facilities, and the U, which is Urban Indian Health Programs, and that makes up the ITU system of care for the Indian Health Service. The 41 Urban Indian Health Programs are serving American Indian and Alaska Native people who are no longer living on their tribal lands or on reservations and villages and currently live in large urban settings across the United States. The last census told us that approximately 70% of all American Indians and Alaska Natives currently live in large urban settings across the United States for a variety of reasons. Some of that was forced relocation. Others was folks like myself who left for educational and economic opportunity. As a direct result of these movements into the large urban settings, and also folks like me who go back and forth in between our tribal lands and to the large cities, there was a need to ensure that the data of the urban Indian experience related to health was captured. And so the Urban Indian Health Institute arose out of that in 2000. So this is our 20th year anniversary. And our goal is to improve the health and well-being of all American Indians and Alaska Native through culturally rigorous evaluation, data collection, epidemiological surveillance, and research. And we are focused and ensured that we are grounded in Indigenous methodologies that says the reason we do this is for the love of Native people and to ensure a great future for the next generations. As a core part of that, when the pandemic of COVID-19 struck the United States, where our offices are located in Seattle, we began to mobilize our response in February of this year. Next. I know we keep throwing around this word surveillance, and I wanted to give a definition of that from the World Health Organization. Surveillance is the data that is being collected in a systematic way for analyses and interpretation of specific data that's related to COVID that can be used for planning, implementing, and evaluating what and how that pandemic is affecting our communities. And so there's a lot of efforts that people are seeing across Indian country right now in collection of data. For example, an incredible effort by Indian country today where they are crowdsourcing, which means they're asking folks, and they're also searching social media posts to find the number of Native people who have identified themselves as having COVID-19. While this is a really great effort, it also has some incredible limitations to that. There is no verification through a medical system that the positive tests that are reported in social media or through crowdsourcing actually that we can verify those through a medical system. And so the surveillance that we do as Tribal Epidemiology Centers is working with those medical systems, the clinics themselves, the states, the data that flows from them. And the Urban Indian Health Institute recognized that the urban Indian health programs were specifically being underreported in this epidemiological surveillance. As a direct result of that, we have launched our own, and we are doing our own surveillance across the 41 programs. That means we are collecting the number of positive tests, the number of tests that they have done, what their staffing currently looks like, where their needs are, where are they currently with PPE supplies. We are going across those programs and we're collecting that information ourselves. So data for Indigenous people by Indigenous people, because we know that the urban Indian programs were not being counted. Next. One of the reasons that our programs were not counted is when you look at the Indian Health Service right now, it's approximately a little bit less than 40% of all American Indians and Alaska Natives in the country actually access Indian health care facilities. The rest of them are in outside hospital systems, outside clinical systems. For the urban Indian communities, this is very impactful because we know that when they go into these hospitals, into these clinics, they're never counted as being Native. So that means when I get data from the states, our people aren't actually represented it because possibly when they received the form, when they checked into a clinic, they didn't actually have a box that said, check this for American Indian or Alaska Native. Or they identified as more than 2 races and they checked American Indian, Alaska Native, and they checked African American. And what happens is that they categorize these people as multi-race instead of disaggregating the data and recognize them also as American Indian, Alaska Native. As a result of these practices of either just not gathering the data at all, misclassifying people, or putting them in multiracial category, we're seeing states across the country not have enough data on American Indians and Alaska Natives. And as a result of that gap, one of the resources that we have put out is best practices for data collection for American Indian and Alaska Native communities. And we are working across several large hospital systems that span multiple states, along with counties and also with the federal government, in ensuring that these best data practices are implemented across the country. Because we know that our people are invisible within the data right now, and one of the roles of the Urban Indian Health Institute is for those living in urban settings who are not using IHS facilities, that they are still captured within the data. Next. In addition to our surveillance of the programs and the resources we provide to local, state, and federal governments, we've also partnered with Native artists to create educational materials. This is an example of one. Anybody who would like a copy of this sent to their tribal clinic, please contact us. We will send you these posters or pop-up banners. We partnered with my cousin Bunky Echohawk and used a trauma-informed response, which is really recognizing that our kids were struggling with what COVID means, how it's impacting them, and we wanted to give parents a tool for them to have these conversations with their children. So this is just an example. Next. This is just an example of the work that we're doing in regards to culturally relevant materials. On our website, we have a list of resources and many more materials like this that can either be downloaded or they can be requested and we can print them and send them to tribal clinics, both urban and rural across the country. Next. I wanted to go through that pretty quickly so we had time for questions. Again, if you are interested in any of these resources or interested in hearing more about what the tribal epicenters are doing, we are going to be having a roundtable discussion across the 12 tribal epicenters next week, next Thursday. Please visit our website for the tribal epidemiology centers, and hopefully Dr. Rubidoux, if you'd be willing to share that, I can't think off my head right now, the address for that so people can register for that, but you can learn more about the programs and the work that each of us are doing. And I want to thank you all for listening and hearing more about what the tribal epidemiology centers are doing nationwide. Thank you.
Great, thank you so much, Abigail, and thank you to all the speakers, especially for Dr. Victoria Warner's patience when the internet connection wasn't working in the beginning, but we will edit the video so that people can see the final video where the slides actually match what you're saying. But to all the directors of the Tribal Epidemiology Centers who spoke today, thank you so much. It's really amazing the work that you're doing, and it is so needed during this time as we see the cases going up and as we see challenges in our communities. We are very worried about our people and our communities, and you're at the front line of helping our communities address COVID-19. So now what we'd like to do is to ask questions, and I actually have several questions in the questions pane, so I'll go through some of those as time permits. We also have several other Tribal Epidemiology Center directors available on the line to answer questions. And so let me start with the questions, and I'll ask the speakers to join in as needed. So the first question is, do these centers receive what they need from the federal government? I have heard mixed messages. Some receive what they need and others have not. Does anybody want to respond to that question?
So I can tackle that question. This is Victoria. Being a long-term Tribal Epidemiology Center director, all of our centers are funded a bit differently. And so if you've seen one epicenter, you've literally seen one epicenter. And so for our particular center, the way the Northwest Tribal Leaders' vision was that it was broader than just just epidemiology. So our center has always been diversified. And when you get my set of slides, that was our first slide to show you the variety of programs we have under our epicenter. So in fact, for our epicenter, which has about 50 employees right now, we are diversified, and the funding that comes through the designation from Indian Health Service makes up about 7% of our operating budget. So from the Indian Healthcare Improvement Act and the funding that comes directly for that title of Epidemiology Center, we certainly wouldn't be able to support the response we're doing currently if we just had those funds. Fortunately, we're diversified and we also receive funds, many of us, from CDC and SAMHSA and other federal entities. So the short answer is, if you're relying on just IHS funding, unfortunately, most of us at the beginning of the COVID-19 epidemic did not have the response that we needed to fully be able to initiate and engage responses. We're very grateful, though, for the funding that was provided, that will be provided to the epicenters in the near future here, that was part of the CARES legislation. So that will help a lot of us tremendously.
I just want to add that Victoria is absolutely correct. There's also a very unique thing to the Urban Indian Health Institute, and that is, as an Urban Indian Health program, as the funds have for COVID response have come out of the federal government, they have not been very inclusive of urban Indian health and urban Indian health programs, specifically our Tribal Epidemiology Center. Often that isn't done on purpose. They don't know to use the right federal language to make sure we get it. And there's also a misunderstanding, I think, nationally, for people outside of the Native community who do not understand that there are large populations of us currently living off-site, off of our tribal lands. But what I always tell them is, we are tribal people regardless of where we live. Urban is our experience. Tribal is who we are. And so we are always advocating for, and it's been a big issue with my organization over the last few months, to ensure that the Urban Indian Health Institute received funds that was similar to what was going to the other tribal epidemiology centers.
All right, anybody else on that question? Okay, the next question is, why do you think that there are large numbers of positive cases on the Navajo Nation?
Thank you for the question. This is Ramona with the Navajo Epidemiology Center. I introduced myself and our clanship, and that is one of the hypotheses that we have among our colleagues at the Navajo Epidemiology Center is we are such close-knit families, and many of our homes are multi-generational and crowded, and it's very common to have Che Masana, who are our grandparents, living with their adult children or child, and living with the next generation of grandchildren, and then even great-grandchildren. So we think when COVID-19, the Kusuntagi, came to the nation, we would have a positive confirmed person that would return home and infect another family member. So that is one outcome, and we see that many times throughout this pandemic. The other is that we have social gatherings that were also seen as super spread, and then also even medium-sized or smaller groups that gather. So of course, when COVID-19 has no discrimination about tribal identity, jurisdiction, if the droplets are there, then it happens. And so we have an understanding about how it may have come into our nation and how it spread so quickly. So I think that the strength that we have in our kinship, the strengths that we have in our individual communities identified as 110 chapters across the 3 states and the agencies That is how close-knit we are. And we also are very mobile people. We have limited resources on the nation, and we travel to border towns for resources and then just the entire response. And I just also want to say that we do not have specialized care to support all the needs on Navajo area. Many of our people are in delay of receiving the care that's needed or in a timely manner, and they are flown out to higher levels of care. And I just want to say that it is long known that Indian Healthcare Services has been underfunded for decades, and I think that this is one of the outcomes to that is when there's a pandemic or an outbreak of any, that we would see the need for care has great limitations on the nation. So those are my initial responses. Of course, there's always more to be said, but that's what I'd like to share at this time. Thank you.
Thank you. I appreciate that answer. I know that it's a little past the hour, but if we could do questions for another 5 minutes, then we'll end the webinar. So everybody hang in there. There's some great questions. One question is, how do you see COVID-19 changing the way the tribal epidemiology centers function or conduct public health services now and after the COVID-19 pandemic is over? Anyone want to try that?
This is Vanessa Crushy from the California Tribal Epidemiology Center. Given the large, state of California and as many tribes and clinics that we work with, we continue to provide our services remotely and via phone. We have been training tribes and clinics to conduct contact tracing and case investigation via webinar, although there is some challenges with connection in some of the remote rural areas. So that has been a challenge, but we are trying to identify different ways to try to make it work so that they get the training that is needed for them to be able to do contact tracing and case investigation for themselves and for their own community. And I think moving forward, a lot of this work can be done remotely. I think the thing that will be missing is the ability to provide connections as tribal community and tribal member. We enjoy the face-to-face interactions. We like to share stories, we like to laugh, and we like to get to know one another. And so this has been challenging in our ability to connect with tribal community members and tribal leaders, but we are still doing the best that we can under the circumstances and are doing a lot of our work virtual and via phone.
Anybody else?
This is Abigail. I just wanted to add something to that, and we're doing a lot of what Vanessa also spoke about in regards to switching to virtual and staying in contact. I think one of the things that folks should know about tribal epidemiology centers is that we work for the communities in which we serve, and so we respond nimbly to them. And so all of us had emergency response plans, which we implemented when the pandemic arose, COVID-19. And so I think we are in a really great place, and that's why the tribal epicenters are definitely a resource. I mean, each of those plans were different for the different areas, because what is needed on the East Coast is different than what's needed on the West Coast than is needed in the Navajo Nation. And so what I know we will continue to do, both now within COVID and after, is ensuring that we are following the direction of tribal leadership and responding to the communities that we serve, to ensure that we are there to support them as they achieve health and well-being for their people.
Thank you. Anybody else? We'll do one last question, which is, oh, go ahead.
This is Christy Duke. I am Senior Epidemiologist for United South and Eastern Tribes Tribal Epidemiology Center. And I think in addition to that, one thing that is changing is it seems that federal agencies are wanting to integrate TECs more into surveillance efforts and figuring out a way that we can work with states and federal entities to get the data so that we can better track the cases in terms of infectious disease. So I do think that there seems to be more attention or more focus on how we can partner with our other public health agencies across the country.
Great. Anybody else? All right. One last question, quick response. Several directors mentioned research as a function of their text. What are the current needs for COVID research? What kind of studies do you see as being valuable and high impact for American and Alaska Native populations right now?
Well, this is Victoria, and I can tackle the start of that question. And I don't pretend to have all of the knowledge of what's needed, but we definitely are looking forward as we continue to move forward. We do a tremendous amount of linkage work at our center with a known registry of American Indian Alaska Native people who receive services in clinics at the Pacific Northwest. And so we will be going when the data is, when we're sort of past the initial phase and things go into a more day-to-day operations, we'll be doing linkages with hospital discharge registries, with the surveillance systems to ensure that we get racial misclassification corrected in those systems. So that will definitely be one of the things that we're doing. We also have had calls from researchers about inquiring around tribal participation in vaccine studies. And so we're acting a bit as a conduit for information in those areas as well. There will be no end of additional public health work that we can do. And this has been an excellent call in terms of, or an excellent time in terms of just really focusing in on health concerns. So there are any number of health issues that I think will need to be investigated and look at what are the culturally appropriate practices that can really strengthen people's immunity in the future, and how can we leverage the strengths that we've seen in our tribal communities. All of those are areas for development of best practice, because certainly many of our tribes have done an outstanding job of responding in this pandemic time.
Hi, this is Ellen from the Alaska Native Epidemiology Center. In answer to that question, I just would like to add that I think we need some validation studies about the various tests that have been released by the FDA on emergency use authorizations, on how well they work in our populations that we serve. In addition, I think another study is we need to understand the prevalence of the study, knowing that in other communities, other populations, there's a large asymptomatic or pre-symptomatic population, and understanding the prevalence and potential immunity of the population so that we can return back to closer to usual activities would be an important serosurvey study that needs to be done.
Hey, I would. This is Tracy Prather, and I'm the Epi Director for the Oklahoma City area. That's tribes in Oklahoma, Texas, and Kansas. I would just like to say briefly, our world has changed. Everybody's world has changed. It has changed in tribal communities. we have a great wealth of knowledge with all the tribal epicenters that are present here today. Across the country, we share best practices. I think we are looking at that change as well. How do we adapt and how do we adopt best practices and utilizing the best evidence-based practices that we can provide to tribes in education, resources, tools, and materials to better support the tribes that we serve. And if I can pull from help from Albuquerque and Kevin in that area, they do great work with Jervin Gonzalez in Great Lakes, with PJ up in the Northern Plains. I certainly do that. Arizona, Jamie Ritchie in Arizona does a fantastic job. We are all plugged in to help each other across the country to help tribes. We're finding out we have to do things a different way as well. We want to help tribes learn sustainability and all these new practices and see how we can help be connected and bridges with funders and funding organizations and the changes that tribes are going through right now as well. So appreciate the opportunity to visit with you today.
This is Kevin English with the Albuquerque Area Southwest Tribal Epidemiology Center. We just go by Aztec to make it easier. One research question that I think is going to emerge in the not too distant future here is to really understand the impact of COVID-19 as really a disruptive force upon healthcare access and health-seeking behavior for tribal members living with chronic illnesses. We all know that many of the community members that we serve currently are receiving care or were receiving clinical care for health conditions such as type 2 diabetes, heart disease, high blood pressure. And there's a lot of evidence out there right now that indicates that people aren't getting the health care that they need, either being fearful of going to clinics or clinics not being staffed sufficiently to provide the routine care that's needed. So I think it's going to be very important to look at how this particular pandemic has disrupted routine healthcare for community members that really need it, and what are the options for interventions to ensure that they do get it going forward.
This is Ellen. I just want to add to what Kevin just said, not only in regards to routine care for chronic disease, but also for prevention. There are reports that there have been delays for immunizations, and thinking forward about fall coming up and flu, and having to maybe think outside of the box about what we can do to improve flu immunizations throughout Indian country.
Anybody else? Well, we've gone way over and there's lots of questions, but I want to be respectful of everybody's time. We have one last comment in the question pane, or one comment that I want to highlight. Tribal leader Andy Joseph says, "Thank you for all the presenters. I send my prayers for everyone working to help our people." And I think that's a great way for us to end the webinar. I would like to thank our speakers for their very informative presentations and the willingness to join us today. Based on the questions and the questions thing, we might have to do this again or have you guys do one again, because there's lots of interest in what you do. And thank you to all the people who joined, the attendees who joined today. Don't forget to complete the feedback form that you will receive in the follow-up email after this webinar. And this webinar will be available as a recording soon once we can edit it properly on our YouTube channel that you could access from our website. Feel free to send the link to the webinar to any of your colleagues who may be interested. And just a couple of announcements before we leave today. We are going to start up our webinar series again. We got behind, but watch our listservs, our social media for the next webinars, or email research@ncai.org and we can add you to our listservs. But watch our website. I also want to encourage you to visit the website link on this slide for the Tribal Epidemiology Centers, our NCAI COVID-19 resources for Indian Country website and our NCAI Policy Research Center website. Again, I want to thank all of you so much for joining today and your patience with the internet connection. I'll have to make an angry call to Comcast once we're done. Anyway, thank you to the Tribal Epidemiology Centers. You're a critical resource while we're dealing with the COVID pandemic. And on behalf of all of us, thank you for your work. It's really critical, and I appreciate your presentations today. All right, goodbye everybody, and have a wonderful day. Remember to socially or physically distance and wash your hands a lot. Wear a mask when you're in public. Don't touch your face, and please be safe. Thank you so much for this important work. Goodbye.